very good morning, everyone, and thank you, DOS President Dr. Vanathy, Secretary Dr. Rakesh, and Professor Dadea for giving me such a nice opportunity. And it's always great to be at your alma mater. For your knowledge, 25 years back, I was here. I was doing my diploma, and I'm really honored to be on this podium. So I was just talking to one of my seniors. He was confused what is ambidexterity. So MB means both, and dexterity means dominant. So both hands dominant is the actually what does it mean? I could not find any other word to describe this. So most surgeons have a privilege of helping hands, like with general surgeon or even extraocular surgeons like squint or plastic surgeons have a privilege of their assistant, using their assistant hand to hold the muscles to get exposure when they are focusing on one side. There is somebody to help them. But we cataract surgeons, we are actually juggling with technologies. There is an assistant sitting with us who is actually help us. They can handle the machines, they can hand over instruments, but inside the eye, they cannot use their hands. So we are like a lonely surgeon. So we are like one-man army where we can use either both hands covering one direction and leave other uncovered, or we can choose to cover more sides ourselves to cover 360 degrees. So practicing ambidexterity definitely improved my patient flow. There are certain personal advantages which I felt, but it also unlocked a new dimension, precision, creativity, and innovation. So it's not only rewiring of skills, actually it's a rewiring of brain. So I'll show how it improved my workflow. You can see I'm operating on the left eye of the patient, completely using left hand as dominant hand, and my position, my assistant, my microscope, phaco machine, everything is there. The patient comes under my same position, sitting at 12 o'clock. Now I'm operating temporal surgery in the right eye of a right patient. Now, because these days, this has given me advantage to sitting at 12 o'clock, I can make incision wherever I want. So any steep axis I can make an incision. And how does it help? I can give an astigmatically neutral incision. It's right from 0 to 180 degree. Yes, that includes nasal side also. Another advantage, cataract surgery is one thing, but the IPCL implantation is technically more demanding. So sitting at 12 o'clock, I'm doing right eye surgery using right hand as a dominant. And in the same sitting, I'm doing left eye surgery using left hand. So both temporal incisions. So it improves it saves my time. There is no need to move from temporal to 12 o'clock. So these are the skills. Obviously, this skill helps in improving patient flow. But it has also, started giving, because I'm using my right half of the brain, which was currently sitting idle for 45 years. So new ideas came to my mind, and I've evolved few things. These are certain new ideas which I have actually established. This is one chopper which I have designed. It has a obtuse angle. So this chopper, I call it mini well chopper shield, because this chopper slides under even small capsulotomy, and it does horizontal chopping. Most horizontal chopper needs large Rhexis or dilated large pupil. But I can do even small pupil, 4 mm without using pupil expansion ring. This is one thing which is very well known. Many people must have seen videos, double tunnel ambidextrous Phaco. Though name is ambidextrous, but actually now I've realized it's possible to follow this technique even without learning ambidexterity. I will be showing in my videos. So how it works? There is no need to hydro dissection, nuclear rotation. There is a better access to nuclear fragments around 360 degrees. And it bypasses the risk zones, like if there is a PC rent, zonal dialysis, DM detachment, iris prolapse, localized corneal opacity. You can negotiate better. So this is like one video. You can see this is a hard cataract, grade 4, 5, 6 cataract with posterior puller. And this patient surgery was being avoided for over last 8 to 10 years. So what I did, I made 2 tunnels. I made 1 trench from the right side, 1 from the left side. No dissection, no nuclear rotation. I simply made 4 quadrants. I removed 2 from the right tunnel and the other 2 from the left tunnel. And so without any pressure on the posterior capsule, you can see this thin fluttering area of the PC, which could have given way if I had tried to rotate or do hydro dissection. So this is another surgery where there is pseudo-exfoliation and Vacuu-Rhexis. In spite of so many efforts, it was not rotating. You can see the bag is, there is zonal dialysis. So I took off, this surgery was being done by my colleague. So I took over, I realized there is a vitreous close to the right tunnel. So I made another tunnel, I debulked the bag, and then came back to the right tunnel. I did limited vitrectomy, made a Hoffman pocket, stabilized the bag, and then I could complete the surgery. So the primary surgeon was scared that this bag is going to drop, cataract with bag. And once bag is stabilized, I'm able to so you can see I'm able to negotiate better in wherever it is required. and this is the post-op image. Another case, if you see, this is unexpected PCR. So you can see there is a rent here, and it's equatorial rent. I immediately changed my tunnel to the right side, did vitrectomy in that area, injected Visco as a pseudovitreous, and completed the surgery using second tunnel. And you will see by the end of surgery, even PC rent was not visible because it was equatorial, and my maneuvers actually prevented it from extending, and you can't even see where the rent is there, and lens is very well centered. Now small people, though this is a case where it is a complicated cataract, young lady with posterior synechiae. So I am doing Visco-less, manual capsulotomy, and because it is soft cataract, it was not rotating. So it was unplanned, but I used second tunnel as a fire exit. So I call it a fire exit now. So whenever you're trouble, you can make second tunnel and complete your surgery. So you can see no pupil expansion ring. It was a complete cataract, and by good synchronization of two dominant hands, it gives you better confidence in negotiating this difficult situation also. This is post-op 1 day image. Now this is how sometimes feel. How does it help? You can see here, surgery is over, floppy iris. Now I am trying to take out this Gupta segment ring. First attempt, second attempt, third attempt, now fourth attempt. Every attempt failed. So then I made my fire exit. I made second tunnel. I actually converted side port to this, and now I am able to. So this was last stage of the surgery. So once you develop use of, get into habit of making second tunnel, so in multiple situations you can have this advantage. Now this is surgery, I was operating, my assistant saw this, I ignored this corneal obesity, but I was finding it difficult to visualize things. Then I again made second tunnel, and now you can see this is the area where the cornea is clear. In this clear zone I am operating, and I have been able to prevent any complication because of hazy view. So there are multiple situations, preoperatively or intraoperatively, where you can actually shift to second tunnel. This is another idea which I actually thought of. I applied, and I recently have been awarded by Professor Graham Barrett in APS-ERS meeting. So this is Visco-less Bimanual technique. So people can't imagine. Now you see, I am using vacuum to immediately aspirate the liquid cortex, and now I am using vacuum to make the capsulotomy. And this is Visco-less capsulotomy. So most people can't imagine that capsulotomy is possible without using viscoelastic in intumescent cataract. And this technique has been awarded in APS-ERS 2 months back. So this is what Professor Graham Barrett personally told me. This is a wonderful physics-based technique, but yeah, surgeons have so much of hesitation to adopt it without injecting viscoelastic. So now, is ambidexterity a trainable skill? If I ask you, most people will say it is a talent, it is not a trainable skill. So I'll show you one video. This is a small school in Budhela village in Madhya Pradesh, where this is a school which is ambidextrous school. You can see they are teaching students how to write with both hands, and you can see even one left hand English and right hand Hindi. Can you see this? So we believe it is a talent. Actually, it's a trainable skill, and and actually I'm going to visit them and to understand this concept. You can see he's two different languages at the same time. So there's something. This village is in India. It has been covered by international community, but we as Indians are not aware about this such a small, wonderful school. So, inspired by this, I have taken a new initiative. Actually, I have made a foundation, non-profitable organization called Sabyasachi Global Foundation. Sabyasachi means ambidextrous. It's another name of Arjuna, who was first ambidextrous, a fighter. So this is taking shape now, and I'm actually planning to create dedicated workshops with wet lab training, and I'm inviting interested colleagues. Our GNEC alumni, Avni and Sonam are there with us. You can connect those who know them. And so I believe it is not limited to handiness in human skills. I'll tell you there is something called organization ambidexterity also. Lately I came to know. So good organization, they use this exploitation and exploration. Exploitation is to run today's business efficiently, and exploration to build tomorrow's growth through innovation. So the example of Nokia versus Apple. Nokia was focused on exploiting the present, while Apple was focused on exploiting the present. But Nokia neglected the exploration for future, and it actually perished. And Apple actually focused on continuously, for future, and where Apple is standing today. So it's like adapt or disappear. Ambidexterity is the key to long-term success. So there was an article published in Times of India, and this about this Lancet published study that dependence on AI may de-skill doctors. This was published in Lancet. So there is a big question. I think most of you, those young people, will believe that AI will take away jobs. There's so many engineers, they feel like this. So for surgeons, in era of AI and robotics, how doctors can remain relevant? So I think Charles Darwin gave this answer long back, centuries back. It is not the strongest or most intelligent person who will survive. It is the one who is most adaptable to change. So I think when we are having good machines in our hand, good microscopes, good chamber stability, it's high time to realize that our left hand, which is wrongly called non-dominant. So I have stopped calling dominant and non-dominant. I call it preferred hand and ignored hand. So we have been preferring one hand since childhood because of some wrong perception, and we have been ignoring one hand. But if you keep working on your ignored hand, so I think this is what improvement in skill. Even Modi ji, our Prime Minister, has recently in last AI summit told that those who will keep upgrading their skills, they will never be threatened by the AI. Another reason, so I would say, push your boundaries, change, adapt, and innovate. And another reason why we should improve our skills is, this is an example. So when technology is our master, disaster happen faster. So this Sunita Williams went in space for I think 7 days, and she had to stay there for almost 9-10 months. And it was her survival skills which made her. Can you imagine sitting in space for 9 months unplanned, away from the family? I think most people will go into depression. But they were trained, their skills were like that, they can stay like this because they knew it can happen. So similarly, whether it is survival or surgical, they are all equally important skills for such contingencies. So when AI fails, when robotics fail, when technology fail, our human skills will always remain relevant. I am aware of surgeons who are very good in Phaco, but when it comes to do SICS, they are not good. And ECC probably when we ask them, so what is this? ECC hota kya hai? So I think we need to keep pushing our boundaries. We need to come out of our comfort zone, improve our biological skills. The only way to remain relevant is to keep upgrading our biological skills, so that whatever future comes, we as a surgeon, we will remain relevant. So anyone who wants any help, I'm always ready, available at a call or a WhatsApp away. These are my contact numbers and email. So I would like to thank you. So you can see, and this is what I learned at last. Now I'm able to write with left hand also. But this is only after seeing that video of Budhela village, I tried, and now I'm able to write also. So, and if I can do it at the age of 45, I think there are so many young surgeons who are budding up. Next 50-60 years are good, available for you. I'll suggest everybody should try this. Thank you, and thank you again, DOS and GNEC, for this opportunity. Any question I'd like to take?
Thank you, Rakesh, for your excellent presentation and such in detail. But I think already Vitreretina, they are doing bimanual